LollieTasking is multitasking the Lola way. Join my mommy and other amazing women as they have random girl talks and laughs, all while trying to live a balanced life. This is LollieTasking.
Welcome to another wonderful episode of LollieTasking. I am your host, Lola, and I am so excited that you have chosen to join us again today. On last week's episode, we spoke to my friend Dr. Tammy, who has been dealing with infertility for 5 years, and we talked about her struggles and things she wished she knew at the time. On this episode, we thought it would be important to bring someone who is actually specialized in infertility. So I have here today with me Dr. Ibrahim, who is a reproductive endocrinologist and infertility specialist. This is Dr. Ibrahim. Welcome again to LollieTasking. I am here with Dr. Ibrahim. She's an OB-GYN with extra training in reproductive endocrinology and fertility. And it is such a pleasure to speak to her today because, one, she is a mother of 2 young kids. And I first of all want to ask you how you found the time.
Oh, God.
The time. After, for those of you guys that don't know, after your 4 years of medical school, you decide what type of doctor you want to become. And it's not until you're done with medical school you realize that that's when the real learning starts after you get your MD,
Correct.
So Dr. Ibrahim did a 5 years residency in obstetrics and gynecology. So
Actually,
she could have.
4.
It was 4,
4
excuse me. Okay, 4.
Sorry.
So it's 4 years. I'm trying to give her extra. But she did not have a remedial year. I'm sorry.
No, thank you.
So she did a 4-year training in obstetrics and gynecology. So she could have just gone and be your general OB-GYN delivering babies, which is a fantastic field. But she had a passion for couples. So she did an extra, how many years? 3 years?
3 years. 3 years.
Actually, 3 years in reproductive endocrinology, aka when they say, I'm going to the fertility doctor, that's who she is. And in the midst of all this 7 additional year training, she got married and she got 2 kids. So, so let's start with, first of all, before we even get into why we're here, because I really want to ask how we balance being a boss, being a professional woman, being an entrepreneur, and going for that goal, but at the same time planning to be a mommy. No, it's not for everybody, right? I have some friends that they're like, you know what, I don't want to have kids, and that's perfectly okay. Or some friends are like, if I never have kids, I'm totally fine with it. But I also have some friends that ever since they were 2 years old, they've been combing their Barbie's hair, and they see themselves being a mom, like their own child. Because I always tell people there are different ways to be a mom. It doesn't have to be naturally. But there's some people who yearn for that natural ability to carry their own child in their belly, the ability to experience that. So we're going to talk more about that in a bit, how we can kind of yes, have our boss life, but yes, have planned our mommy life. But before then, I really want to know how you balanced the stressful OB-GYN residency. And don't let anybody lie to you. Residency is stressful no matter what you do. But I feel like OB-GYN was just a teeny tad bit stressful than some other residencies, right? Because you have 2 lives in your hands, not just one person. You also have the child's life in your hands. So how are you able to balance that with the crazy work hours you guys used to have? And then got married. And they had 2 beautiful kids. I just want to hear how you did it, first of all.
Well, thankfully, it didn't all happen at once. I got married about a week after I graduated medical school. So that one happened pretty quickly in the process, thankfully. But we did not try to have a baby until my 3rd year, actually towards the end of my 2nd year of residency. And it just so happened that it just took. it happened pretty quickly, thank God. And the pregnancy was tough because I suffered from hyperemesis in the first part of the pregnancy, in the first trimester. I
That makes
lost
you
about
throw up all the time, by the way.
That's correct. It makes you throw up all the time. You can't keep anything down. I lost a good amount of weight during that period of
When
time.
you're supposed to be gaining weight.
That's correct. And I did not miss a day of work despite all of this. And sometimes I think back to that moment and I think to myself, I do remember times driving to work and stopping on the road to vomit into a bag. And when I'm done doing what I'm, vomiting into a bag, I just keep going to work. Um, but it was just one of those things. I just kept going, and it was just one of those things where I told myself that I wasn't going to delay any further for my career to be a mom because it was always something I knew that I wanted to do. Now I knew that I wasn't going to be somebody who wanted to have a lot of children, but I knew that I wanted to experience it, and I didn't want to wait. So I just, I did it. I did the first one then during residency, but very quickly after I had her in my third year of residency, I knew I wasn't going to do that again during residency.
Reality kicks
So
in, y'all.
reality kicks in at that point in time because it was really hard. I was a chief resident, my fourth year of residency, and I had a baby at home and I worked crazy hours. I didn't see her a lot of times, and it just wasn't something that I enjoyed. But I knew that the end was near. Um, Unlike most people who traditionally just go straight from residency to fellowship, I actually did not. I did not apply right away. I I took a gap year where I just worked part time, and it was during that gap year that I had my second. So that was a much
Or,
better pregnancy in the sense that I
or,
wasn't working so much. I was doing locum works, and I had my son. But I knew at that point, before I conceived of him, that I wanted to do the fellowship anyway. So I went ahead and applied for the fellowship, and then had my son, and then started the fellowship. So that was how I did it. But
oh,
yes, it
wow.
was hard to have the first one in residency. I knew very quickly that it was going to be hard to carry another pregnancy while working.
Yeah.
So I deferred the second one until that gap year, and we hustled for fellowship.
Talk about
It's what it
planning. I'm with you. I almost wish I did something similar, but not everybody is crazy like I am. But some people actually plan. Um, okay, so was your husband working? Like, was his job more flexible? Or was your mom around? Did you have family support? Like, how did you do it during, especially with your first? Well, you had a daughter first,
I
correct?
did. My daughter was the first one. But yes, I mean, the good thing about his job is that he has that flexibility whereby if he had to work from home, then he had to work from home. And he was great in the sense that he helped a lot with those responsibilities, like dropping my daughter off at our nanny or whatever needed to be done during those early periods. But what I initially did was my mom came to stay with us for about 2 months when she was a baby.
That's awesome.
And yes, and then we had a nanny that we would take her to for a little bit after that. But then it became really hard because my hours were really bad. So we got
Uh,
somebody to come live with us who helped with her for quite some time actually. So and then you know how it is, mothers come and go.
mhm.
His mother
Mhm.
came, helped her a little bit. And we just hustled like that until she was 16 months, and then we put her in daycare. And that's what we did.
I would say like I mean just going back to when I had my kids, like the
Uh-huh.
support that my mom gave and even my mother-in-law came. I had an aunt who came. It was like a rotating door, so to say, of
Exactly.
support system. And while I always loved my mom, hands down, everybody knows I love my mom. I don't think we appreciated our mom
My
until
God.
after we had our own, and we're like, oh gosh, so this is what you went through, like.
Exactly, exactly, exactly. And that's exactly. And you know what? My mom always said that to me before I had kids. She said, well, let's wait till you have your own. We'll be having more serious
Uh,
conversations.
And
Then
and
you
I feel like
realize.
something twists from, oh, that's my mommy to like, wow. you're an amazing woman, and I cherish. I want to be you.
Exactly.
So with all that being said, I'm sure some people are listening to us and like, oh wow, I would love as much as we talked about how hard it is. Some people still they're like, fine. I know sometimes when I complain about how difficult things are and
Mm-hmm.
or when I complain to my mom, like, these kids, I literally just cleaned the house and they just messed it all up. And she's like, that's the prayer some people pray.
Oh,
Like
yes,
in my native language, Yoruba is like Adura Tawelumingba.
of
It's
course.
like
Mm-hmm.
that's the prayer some people are praying for. And it
Right,
really didn't hit me till I started having some friends going through infertility issues,
right,
right? I was
right.
lucky to have known my husband, good Lord. Like, we've been together for 18 years now. We've been
Wow.
married, yes, we've been married for 10.
Mm-hmm.
We were together for 8 before we got married. So dated
Wow.
6, engaged 2, so 8 total, and then we got married. Married for 10 years. But I was lucky in the sense that I met my soulmate earlier, right?
That's right.
And I was talking to one of my other friends, and I was like, when I was in residence, because I was actually very, very interested in OB-GYN, but I didn't do it because of surgery. I did not like the surgical aspect of it. But
Fair enough.
uh, there was a OB attendant who basically we asked her, we're like, so what's the best time to have a child? Because you know how they talk about the curve at like 20 something years, your ovary starts to dwindle and fall. And I'm looking at this kind of like, yo, I just passed that 2 years ago. you know? And I was like, so what's the best time to have this? And she said, the best time to have a baby in medicine is when you are able to have the support system. There's no best time essentially, right? Is when you have that support system.
That's right.
And she talked about how as women we should be doing both. Don't
Mm-hmm.
just focus on your career and don't just if you really want a family, you have to find a way to do both. And I think that was one of the best advice I ever got
Yep.
because with my type A personality, I could see myself being like, you know what? I'm going to wait till after fellowship because
Mm-hmm.
I don't want anything to distract me, okay?
Mm-hmm.
But having that advice in my mind, I was like, okay, so I mean, we were married for 2 years before we even had my daughter, but we're like, okay, so let's just keep it going. We're gonna get the support we need. Grandma, you're on board. You're on board. Okay, good. Let's do this. But not everybody had that advice. And my guest, so this is the part 2 of the podcast. My guest I had earlier, she went through the same training I went through.
Oh,
And
really?
after, yes, and
Mm-hmm.
after what, 7 years of residency and fellowship, kind of like yours, after 7 years of residency and fellowship, finally met her husband at 36,
Mm-hmm.
37, 38, trying, nothing happened. And what we were taught in medical school is wait a year, right? However, like, that's for younger people, right?
Yeah, that's for those
Right.
under the age of 35.
Exactly, but she's like, that's not, and she looks, when we say black don't crack, that's my girl.
Mm-hmm.
Black does not crack. She's 40. She literally looks like she's 27. Okay. And she started having all these issues. And when we talk about it, she was like, I really wish someone talked to me earlier.
Mm-hmm.
Basically, how you got that advice. I wish someone advised me earlier. So it
Mm-hmm.
brings me to my question to you.
Sure.
What are the things you think because I'm a independent woman, strong woman. I believe if you want to be a boss, go all for it. But at the same time, you have to be practical.
That's
Is
right.
there really such thing as a biological clock? I kind of just asked you that, but I want you to answer it. One. And two, if there is what, can you slow it down? If not, what are some things you can do to make sure you can be that boss, but end up being a boss and a mommy?
Absolutely. So your first question, is there a biological clock? Absolutely. Absolutely, there's a biological clock. And this is one of the things that I love to talk about. A woman is born with the maximum number of eggs that she's going to have. So it's
That's
interesting. It doesn't make any sense, does it? Right?
Mhm.
Yes. It's interesting that the maximum number of eggs a woman is going to have, she has it between 16 weeks and 20 weeks when she's still in her mother's uterus.
Good Lord.
From that moment onwards, you have a loss in that number such that by birth, a woman is left with 1 to 2 million. Now, it's not as if a woman can get pregnant between birth and puberty, right? So we're not ovulating at that point in time, but there's still a natural attrition that's occurring. So a woman has 1 to 2 million left at birth, but by the time you actually see the first ovulation at puberty, she's already lost about 600,000 of what she has left. So
How is she losing it?
it's a process. So it turns out that even though we're not seeing anything biologically, it seems to be like this phase where everything is all quiet.
Right.
Follicles are still forming in that ovary, and they're still dying. They're still getting to a certain stage of development, and they just die off. So that's still happening, regardless of whether you're ovulating, you're pregnant. It's a very, very interesting biology. So it turns out that that's happening, such that by the time a woman ovulates for the first time, which on average is around 13 years of age, she's left with only 400,000.
Hmm.
Now, with every ovulation that a woman has, which is an average every month, she loses 1,000 eggs. She loses
Oh,
1,000
wow.
eggs for every one egg that's ovulated. That actually completes the process to ovulation, such that that big reproductive window is what I like to call it, which is from puberty to menopause, is so short. A woman only goes through about 300 to 400 ovulations in a reproductive lifespan. Menopause is when everything stops, whereby she can't get pregnant anymore, which on average in the United States is 51. So it turns out that this whole idea of when is the best time is somewhere in that window, of course. And obviously, it's dependent on what the woman's situation is. But I do think, and I've thought about this for many years, that general OBGYNs have a role to play in discussing this reproductive window during well woman visits, whereby, say you have a woman come in who's 33 years old who doesn't have a plan. There's nothing wrong in
Right.
asking her, like, what's your reproductive plan? Like, what are you thinking? You don't have any children? We know your G's and P's, like your how many times you've been pregnant before, whether
Hmm.
you have any children. What are your plans for the future? I don't think it hurts to ask, because it turns out that a lot of women don't understand that whole concept of ovarian aging, that the ovary ages way faster than your body ages.
Right. Right.
So it's a really tough discussion, but something that needs to be had with women at some point during their reproductive window. So now the other part to your question was, how can you balance it with a career? I think the important thing is just knowing, first of all, that I have this reproductive window. Some things change drastically, especially when a woman approaches the age of 37, 38, whereby we have this natural normal attrition that I talked about that's occurring over a person's life, even before they're born. But it becomes way more rapid around the age of 37 to 38. So roughly about 13 years before the average age of menopause, which is 51. So it's like it's going down slowly prior to then. And then all of a sudden you hit 37, 38, and it just picks up speed.
Just
You're losing
wow.
eggs like no man's business. And it also turns out that once you get to that age, Mother Nature has designed it in such a way that you ovulate the better ones before the
Hmm.
less quality ones. So
Right.
there's also the risk of abnormalities in the eggs when it continues the cell division that it's supposed to be doing. That goes up with age, such that what we call advanced maternal age in the world of obstetrics is 35.
Yep.
35 is
Yep. By the
advanced
time you hit
maternal.
40, you're geriatric.
Oh yeah. Oh yeah. I mean, our classic textbook that we read in REI tells us that prior to the age of 35, approximately 10% of the eggs that a woman has are abnormal. That's prior to 35. By the time a woman gets to 40, that number is up to 30%. By the time she gets to 43, that number is up to 50%. By 45, virtually 100% of them are abnormal. So
Wow.
it has to be sometime before, you approach that rapid loss of eggs that you start to figure out, or make a plan as to what to do to, you can't necessarily prolong it, but, some sort of insurance.
Yeah,
Call
definitely.
it.
So
Right.
it's quite interesting. So let's say, for example, you're 30 years old. I mean, 30 is young. I mean, given our
Absolutely.
age, right? I see 30 as young, right?
Right.
But your ovarian age is quite old. I think we need to start thinking of it that way. So let's say you're 30 years old, you're still single, you don't have a boyfriend,
Mhm.
um, and you're still grinding. Maybe your plan is to be the CEO of some Fortune 500 company and you're all in.
Mhm.
What would you advise that kind of woman to do?
So this is always a very tough conversation because I wish this was something that we had a lot of data on.
Mm.
So the American Society of Reproductive Medicine actually doesn't recommend. The way they phrase it is more like you can offer it, but we don't recommend that you perform elective egg freezing to circumvent the natural aging process. Now, why would they say that? It's just mainly because we have no data because we're all doing it, right? We're
Right.
all talking to women who are interested in this,
Yeah.
who like to freeze their eggs because they don't necessarily have a plan within the next 5 years to have children, just as a form of insurance, right?
Right.
Just in
Right.
case down the line, say I meet Mr. Right in 5 years, we start trying by 36, 37. If it doesn't work out after 6 months of trying, at least I know that I have this potential insurance, like
Right.
frozen somewhere that I could go back to as a backup plan. So I think it depends on where she is and what her understanding of the process is. Definitely something that makes a big difference is a test of ovarian reserve for the woman at that point in time, which can easily be done. I like to do it early in the cycle just because I feel like you get a good look at everything. You can do an ultrasound and count the number of tiny follicles that she has at rest in her ovaries, or you can do another test of ovarian reserve, which is a blood test called anti-Mullerian hormone. It can
Okay.
sort of give you an idea, roughly, compared to women of your age, how many eggs you have left in your
I
egg
see.
bank, pretty much.
I
And it,
think that's fair because then you can kind of say, okay, I still have, I don't know, 500,000. I don't know what you guys used to estimate. Or let's say I still have 50% of where I need to be or something. So I could
mhm.
chill a little bit, right?
Right.
Or they're dwindling fast. So I need
That's
to
right.
freeze what I need to freeze at this
That's
point in
right.
time. So
Absolutely.
I think that's a good point to make. And then I've also heard
Something.
stories of people who actually froze their eggs and after um 4 or 5 years or whatever, they do IUI or IVF or whatever and it still didn't go through. I know people use freezing eggs as a guarantee, but is it really a guarantee?
Nothing is ever a guarantee in this field. I never use that word. I prefer the word insurance.
Mm,
It's not there's never a guarantee in what we do because we cannot claim to usurp divine power, right?
right.
So it's all about numbers. We're crunching numbers and telling you that based on this large population of people that have these numbers, these are your chances. It's probabilities, right? And you just hope that that person falls within the probability that you've quoted for them, essentially based on the data that you have. So I never tell anyone that it's a guarantee. I prefer to use the word insurance because
I
that's kind
know
of what it
it's
is.
it's
Right.
so hard though,
Yeah.
because everybody wants a guarantee, but obviously nothing can be guaranteed. What?
Absolutely. And then one other thing that plays into that issue, which is very, very important, is that there's a big part of it that people don't talk about a lot, which is the lab. The lab that takes care of those eggs make a big difference in how well
Hmm.
they survive the thaw process.
I
Now,
see.
we've come a long way in survival of embryos as well as eggs. But it turns out the egg is actually the largest cell in the entire human body, like the largest one cell in the human body. And it can form a lot of ice crystals when we're using our old forms of freezing. But we've gotten to a better form of freezing the eggs where they can, 90 to 95% of them can actually survive the thaw. But that even, an egg surviving the thaw is no guarantee that the chromosome numbers are normal.
Right.
So that's another thing that plays into what exactly ends up happening when someone goes on to use that particular egg in order to try to create an embryo in the lab for transfer.
And what you talked about the lab, I don't think I've actually heard too many, even general OB or even lay physicians talk about the labs that freeze their eggs. So how would you know which lab is good? Like I feel like
Egg
this is amazing
freezer,
because I don't think it's something I've really thought about. But it
right?
makes sense, right? So, but like, how
Absolutely.
would you know?
Honestly, that's the part where the data is lacking for egg freezing. But you can only judge based on live birth rates per, when you look at a particular clinic. That's the only way to really know. So there's a way that people can actually check those rates online. There's an association. It's like Society of Associated Reproductive Technology, SART, and they actually receive the cycles that are done in over 90% of the clinics in the United States. Not all of them, but as much as 90% of the clinics in the United States actually send their data to this clinic. So you can actually look at individual clinics and their live birth rates in those clinics. And that honestly is what the layman can look at to try to figure out exactly what the success
Where
rates
to
would
go?
be based on
Right.
the patient's age,
Okay.
or particular situation. But other than that, yes, I mean, unless understand a little bit of the nitty gritty of what's going on in the lab,
Right.
there's no way you can judge that except by looking at some of those numbers that are published in terms of live birth rates.
So,
Egg
what was
freezing
the
on
name?
itself.
Yeah, what was the name of the website again? Just so people can like
Sure.
look at that if they needed to.
Yeah, so it's www.sart, S as in Samuel, A as in Apple, R as in Rabbit, T as in Thomas, .org.
Okay,
Yeah,
that's
and you can
fantastic.
literally just try to find a particular clinic and look at the results of that clinic in terms of their outcomes.
Okay. Um, what would you say, with your experience in area, what would you say is the biggest misconception that the regular people have about reproductive health
Mhm.
or your profession?
So I think the biggest misconception that people often have is this assumption that their own particular situation is the same as everybody else who's gone through
Mm,
infertility. So
yep.
you can have situations whereby a woman who's been evaluated by a physician is found to have a particular diagnosis that just automatically just makes it so much more difficult to treat. One of the things that comes to mind is, say, for example, a woman who has quote unquote diminished ovarian reserve, whereby we the we're essentially telling this woman that she doesn't have what we expect to be the same number of eggs as women of her age, based
Mm,
historically on whether they've cycled before and how they did in that cycle, or just
right.
based on a test of ovarian reserve, right? Like, for example, they get an AMH of zero point 0.1 when we anticipate that most women of our age should be anywhere between 1 and 3. So say, for example, that woman goes through an IVF cycle and is not successful using her own eggs, and the physician recommends donor eggs. And then she goes through a cycle with donor eggs and gets pregnant, and then finds out that, oh, but a friend of mine who's exactly the same age as me had the same issue, but guess what? They had a pregnancy with their own IVF cycle. Well, it's not the same thing for everybody. It's
Right.
so it's one of I find it is a recurring misconception in the sense that they think that they've learned about somebody else's situation and why wasn't that situation, or why wasn't that the outcome that they had when they went through the process.
Right.
And obviously it happens in other forms of infertility as well too that does not involve IVF. So IUI or just treatment of ovulation induction for patients who are not ovulating regularly. Why didn't that work for me when it worked for my friend? All she did was take Clomid and she got pregnant in the second month of taking Clomid. I've been doing it for the past 6 months and it hasn't
Yeah.
happened. So, and I think it's important. We try to stress that, there are no guarantees. We can only work with numbers here and do the best that we can for your particular situation. But there always seems to be that misconception in the public.
Do you there's some cases I've seen also where like people I know of or I've seen are like 35, they're single and they just, they're like, you know what, forget it. I'm just gonna have a donor sperm, use my egg. How often do you see that? Is it as rare or as common as we think, especially in our minority population? Do you see that a lot or?
Um, so where I did my fellowship, where I didn't see a lot of minorities.
Okay.
So I can't speak. I can't speak a lot about that, but I wouldn't say it's uncommon in a lot of
Okay.
places. I'd say a lot of women are aware that that exists and go for
Right.
it.
Right.
So it's something that we have a lot of experience with,
Yeah.
essentially. Hmm.
Okay.
That's
Another
right.
thing I think I also want to like just make people aware. It's most recently it's been kind of like my educational mantra, if I may, just like educating the younger generation, like yes, you could be whatever you want to be, but at the same time, you got to know what you want in the future as well.
That's correct.
Um, and I've heard some people tell me, well, Halle Berry had a child at 40.
Hmm.
Beyonce just had twins. Like, can you speak to that? And just, I know what my thoughts are on this, but I just then to hear from you. Yes. How are these celebrities having kids at 55?
Are you asking me to guess or to
Uh,
just tell you what I think is the most likely
Most
situation?
likely, because I know you weren't there, and if you were, you can't really talk as a people. So,
Exactly. I would say that, it's biologically very difficult for me to believe that somebody at the age of 55 has any normal eggs left. So my guess would be they're using donor eggs.
right. So, what Dr. Ibrahim is trying to tell you guys is stop comparing yourself to Halle Berry and Beyonce, okay? Because who
And
knows what
Beyonce is
Beyonce?
young.
I'm not
Beyonce is
saying
probably in
Beyonce didn't
her
have her
50s.
own child. Like I don't want rumors started now. I was not there. I'm not her physician. All I'm saying is you don't know her particular situation. You don't know. She could have been the one in a million that has all her eggs, still all 2 million of them at 35. Okay, and she had her kids naturally. But you're not her, so you just can't say, well, people are having kids later. And what I'm also starting to realize is that a lot of people don't talk about the challenges they have in having kids.
That's
Okay?
right. That's right. And that's another thing that, always should come to light is, especially from some where we're from, Lola Day, where there's a stigma, normalize the process of seeking help for this so that you don't suffer in silence. I mean, we've talked a lot about ovarian aging. We haven't talked much about infertility. I
Right.
mean, there are people that are really struggling and just, go for an evaluation. Are told that everything looks okay. And I'm talking obviously in places like Nigeria. And then they're told to say, pray. I actually had somebody tell me that recently who told me what she'd been going through. And then, the doctor said everything looks fine. So I think you can just keep praying and taking your vitamins and hoping for the best. And I said, well, I don't think that's a good idea for you to keep doing that because
Right.
this is some things that are concerning about the testing that you've had done. And I think you should present for more testing and consider this treatment modality. But if you wait, that's actually, to me, that's the opposite of what you should be doing because we've talked a lot about ovarian aging. The
Right.
longer you wait, the less likely you can be helped. So,
Exactly.
you know, But you'd have to break those stigmas, those barriers to seeking the help that you need because I don't know whether it's embarrassment or you don't want to be called a name. And
Mhm.
let's not forget the fact that it actually, especially in places like Nigeria, it actually might not be the woman who has the problem. So,
Can I get an amen?
this assumption that the woman is the one who's bearing it. And people say this all the time. Well, maybe he's had a kid somewhere before. I was like, yeah, but situations can change. He may have
Right.
had a kid
Right.
before, but he may be contributing to the infertility right now. We don't know if you don't evaluate. You
Mm.
assume that you're the one, but it might not be you.
Yeah.
So normalizing the process of seeking help for this is one barrier that we do need to break in places, some of our
Yeah.
cultures,
I,
actually.
I absolutely agree. And I love Michelle Obama's book,
Okay.
Becoming. And one of
Mhm.
the reasons why I love that book was the fact that she so normalized the fact that, you know what? We had a fertility issue. And to be honest, like the Nigerian me was like, oh, I can't believe she let people know that, you know? Obama is loved by a lot of people, right?
Mhm.
And she made it known that, listen, I had my issues and I had to get help.
That's right.
And it's amazing that, I mean, that was amazing. And I really want people to talk more about it and it not be stigmatized. I
Mhm.
think it's just recently that our friends, like our age mates, are talking a little bit more openly about it. I don't think our parents' generation did that. Like, you never knew. Um, what they were going through, even if they adopted. Like you
That's right.
just saw a child appear, like you didn't know anything. And I totally agree with the normalization. So we did not talk about infertility at all, but I want to just maybe touch on like a common things that people could be going through. Like I know things like endometriosis, PCOS,
Mhm.
fibroids, just like common things that I feel like could be easy and simple that maybe they could have dealt with if they gone in earlier. Just briefly, I know we can spend like 10 hours talking about this.
That's right. And I think the one thing is, this whole idea of understanding what a normal menstrual cycle is another thing that it turns out a lot of people don't know. Um, a woman being able to say, are my cycles regular is actually a very big, important piece of the puzzle. So if my cycles are not regular, then it's not likely that I'm ovulating regularly. So I'm, in essence, diminishing my chances of actually getting pregnant if I'm not ovulating regularly. So that's a big part of it. And conditions associated with anovulation are not terribly uncommon, whether it's PCOS or it's a woman who, is an exerciser and has lost significant amount of body weight, whereby
Right.
she just can't ovulate, on her own based on that stress level and that energy imbalance. But just recognizing that those patterns in one's menstrual cycle is a big key to it. Now, a couple of things are also play into it. So it turns out three things that really need to be functional in order for pregnancy to occur is that you should ovulate regularly, suggesting that you have eggs and you're releasing them in a timely
Right.
fashion and in a regular fashion. Then you should have fallopian tubes that are open or patent and working because they serve as the conduit where the sperm and the egg meet. And then obviously there should be sperm. So those three things are the barest minimum that should be present in order for a pregnancy to be able to occur. So knowing from that menstrual cycle whether they're regular or not is a big piece of the puzzle. And I would just say you don't have to wait the whole 1 year before you're 35. If your
Mhm.
cycles don't come for 6 months, just go get help right away because something
Right.
is something is wrong. That
Mhm.
whole wait a year less than 35 to seek help is when your cycles are regular, when you don't have, painful periods, when you don't have anything that you can see, or you've been told that you have that could affect your fertility. That's where that comes from. But if there's clearly a problem, seek help for it. Now, the fallopian tube, multiple things can affect it. So endometriosis is one of the things that you talked about, whereby a woman potentially could form scar tissue that could affect tubal motility. And in fact, endometriosis goes as far as actually affecting egg quality and the ability of the egg and the sperm to meet and things like that, so that it makes it difficult for pregnancy to occur. And then other things like, having previously had a sexually transmitted infection that wasn't treated right away could damage the tubes and actually cause problems in terms of fertility. Women who've had prior big abdominal surgeries close to the pelvis can form scar tissue that could actually damage the tubes and make it difficult for that meeting to take place. Having uterine abnormalities don't tend to really cause infertility per se, but say a woman has a fibroid that's sitting on the inside of the uterus where the embryo should normally implant, so where the pregnancy should actually occur. Right. So more often than not, the pregnancy could implant, but they could suffer early pregnancy loss or, problems with the implantation itself because of something within the cavity. So we don't tend to think about those uterine problems causing infertility as opposed to it causing problems with the embryo implanting or early pregnancy losses per se. But that's also a piece of the puzzle. If a woman has that and is having problems getting pregnant, then one might want to evaluate for that as well too. And then sperm issues, which more often than not is just silent.
Right. Exactly.
More often than not is silent until it's evaluated for. So
do you before we're gonna wrap up soon, but I just, when we talk about fertility, I always wonder about guys. Do you have issues with guys wanting to get tested? Like, I feel like women are more open to be like, oh, let me go check on myself. Like, do you feel like it's a little bit harder sometimes for the guys to grasp that they can also have an issue?
I think as people are getting, more knowledgeable about these issues, which obviously times have really, really changed, it's not so much of an issue right now, but there are still some that would give you a hard time. There's still some that would give you a hard time, but I would say much better than it used to be back in the days.
Okay.
I mean, people didn't even want to think about it, that they could be the one with the problem.
Right.
Back in the days. But I think as people are learning more about these things, they're realizing that, help can be found. So we might as well get it checked because we just don't know. It could be something that's silent. So I would say that it still happens, definitely, but not as much as it used to.
Okay. So I'll say in basically summary, the main thing is, if you're 30, let's just put a number out there. If you're 30 and you're not dating anyone serious, or even if you are dating anyone serious and you don't think you're going to be having kids anytime soon, you should at least talk to your obstetrician, your OB-GYN, when you go for your yearly checkup to just talk about your future plans on having kids. Like,
I think it's definitely reasonable to bring it up.
Right, bring it up and talk to them about it. Just like they ask you, how are your periods? It's part of your overall OB health, and just say, I'm still single. I'm just wondering what my options are. And at that time, maybe a good time to talk about, are my periods regular? Am I having issues?
That's right.
And maybe yes or no, they may want to refer you to a reproductive endocrinologist, depending on whatever your situation is. But I think it starts with talking. If you don't talk to your obstetrician about it, there's like really, it's hard for them to help you, essentially, if we don't help ourselves. And like I said in the beginning, I'm a big believer of a woman can do whatever she wants. But at the same time, we need to remember we were born with all the eggs we have. And I am still amazed. I don't remember learning that in medical school that you lose 1,000 eggs with each cycle. Like, I am still freaking amazed by
Well,
that.
I
Oh
always,
my
phrase it
goodness.
that way. For every egg that a woman ovulates, she
Right.
loses about 1,000. And people are really surprised. I think they talked about it, but it was glossed over.
Yeah, I totally glossed over that part. I'm not gonna lie. They probably talked about it. Let me don't give my med school a bad name.
Fair enough. Fair enough.
They probably
Ah,
did.
yeah.
But yeah, it's so interesting. I really appreciate you being here, Dr. Ibrahim. One thing I always ask my guests, I am so big on quotes. I live by
Oh,
quotes. Like I have, if you could see my closet, I have like quotes everywhere. It just inspires me. So I'm always amazed, wanting to hear what people's favorite quotes, proverb, inspirational verse, whatever it is. I always want to hear it.
so it depends on where you want me to get this from because there are so many things that quotes I come across that I really like, but some come from the religious books.
Hmm.
Some come from just movies. So it depends on where you want me to pick the one that I want to talk
Pick
about.
whichever one you think speaks
Whichever
to you
one.
the most and why.
Um, so I would pick, I guess I'll go with Forrest Gump, which is very funny, right? I would totally go with Forrest Gump because it's just one of those things that always amazed me. When he says, life is like a box of chocolate.
Oh my
You
God.
never know what you're gonna get. You really don't. And it always speaks to me in the sense that this idea that you have control over anything that's going to happen, which comes back to what we're talking about here, reproduction and infertility and whatnot. This idea that you feel that you have control over anything, it's an illusion. You really never know what's coming for you and what you're gonna get. So best to be prepared for it or find a way to prepare for yourself for any situation you find yourself in. That's why it speaks to me.
Yeah,
Um,
I love that quote too. Yeah.
yeah.
Well,
Mhm.
I know you have a long day tomorrow. I totally appreciate you taking time out. This has been very interesting and educational too for myself and I'm sure for everybody listening to this show today. And we really appreciate you being here today, Dr. Abraham. It was great.
It was my pleasure. Thank you for having me.
Awesome. Thank you. Thanks for hanging out with us on another episode of LollieTasking. If you have any questions or any interesting topics you want for us to discuss, you could contact me on www.lollietasking.com. On there, you'll also find our show notes, which includes various information specific to this episode and links to our various social media platforms. If you've liked what you've heard today, just go ahead and click that subscribe button, rate the show, and of course, share this wonderful podcast with your friends. Till next time, this is LollieTasking.